Welcome and thank you for joining us in this webinar. My name is Estela Citrin. I will be moderating this webinar about the best master lectures in the ISSM meeting in Rio last May. I'm sorry. So, as you know, press the button of show caption on your screen and choose the language of your preferences to be able to understand better the doctors we are having tonight. And you know, the ISSM vision is that we like to have every human being has the right to a healthy and satisfying sexual life. This is the vision of ISSM, and our mission is and purpose is to become the most respected and trusted source of information, education, and professional development in the field of human sexual health. We achieve this through the delivery of world-class publications, research findings, and both online and in-person opportunities for knowledge exchange worldwide. Next. These are the affiliated societies that we have, and in this opportunity we will have the master lectures that took place with the SLAM's associated affiliated society in Rio de Janeiro. And you also know the other affiliated society, SMSNA, ISSM, ISSM, MES, and IPM, and ISSM, and the ISWISH, of course. And these are the journals that ISSM helps to deliver worldwide. We really enjoy to have them available for our doctors, and it is quite easy and very important for you to participate actively. So feel free to contact and try to publish your papers on them. So as I already said, my name is Estela Citrin. I am from Uruguay, and I will be moderating this webinar tonight. The program is that we will have Dr. Yafi with a recorded presentation on artificial intelligence in sexual medicine, attributes, current status, and potential for future use in sexual medicine. Then we will have Dr. Fairbanks talking about Botox for vaginismus, is it a cure? And Dr. Glina from Brazil talking about the advancement in therapy for erectile dysfunction, novel agents, and treatment strategies. There is a Q&A button. We strongly suggest you to post your questions there, because otherwise sometimes in the chat they get lost and we don't have the opportunity to answer your questions. So please make sure you always post your questions on the Q&A button, and also say from which speaker you will like to answer your question. So I think we will have Dr. Yafi presentation that, as I said, he pre-recorded it. In case you don't know, Dr. Yafi is Associated Professor of Urology, Chief of the Division Men's Health in Reconstructive Urology, Director of Men's Health and Newport Urology at the University of California. His practice is specialized in men's health, erectile dysfunction, hypogonadism, Peyronie's disease, prosthetic surgery, male voiding dysfunction, enlargement prostate, and male infertility.
Hello, and thank you to the ISSM for this invitation to present in the ISSM webinar series. My name is Faysal Yafi. I'm at the University of California, Irvine. Unfortunately, I cannot be with you in person today, but I will be talking about artificial intelligence in sexual medicine, attributes, current status, and potential for future use in sexual medicine for men and women. Here are my disclosures. None of my disclosures are relevant to my talk today. In terms of outline, I'll talk about the definition of AI. I'll discuss AI in urology, AI in sexual medicine, AI in infertility, and discuss some ethical issues pertaining to AI. So if we start with AI as a definition, there are numerous definitions that we can consider. One of them is machine learning, which is develops algorithms that allow computers to learn from data. It can be supervised, which is a labeled data set, unsupervised, which is an unlabeled data set, or deep learning, which is neural networks with multiple layers. It can be neural language processing, which enables computers to use understandable language to humans. Example, ChatGPT, Claude.ai, and other systems that we know of. And this may lead to text generation, question answering, context extraction, classification, and machine translation. It can be expert systems. That's when computers start mimicking experts. It can be speech, such as speech to text or text to speech, vision, such as image recognition and machine vision. It can be planning, which allows machines to autonomously decide on actions based on available data, and robotics, which we are very familiar with in the realm of urology. So if we look at the statistics of the usage in clinical practice, this is a looking at diagnosis. In 2018, 15% of major urology centers use AI. In 2020, it was 30%. In 2022, 45%. In 2023, more than half of major urological centers use AI for diagnosis. And if we look at surgical training, 10% of residency programs use AI in 2018, 25% in 2020, 40% in 2022, and up to 50% in 2023. So again, an increase in the interest. Moving to AI in urology, there's some data on pediatric urogynecology, transplants, and urology, andrology, and incontinence, and the majority of it is in urologic oncology. If we look at AI in urology, it can be used for disease diagnosis, image identification, outcome prediction, surgical improvements, and clinical and outpatient settings. When we look at data on AI in urologists, this is a survey of 456 urologists with a 64% response rate. 47.7% use AI in academic practice, 20% use AI in clinical practice, and 60% believe that there are potential ethical issues pertaining to AI. And 53% said that there were limitations with software such as ChatGPT. If you look at it, AI and patient trust, this was a survey and it looked at patients' preferences, and you can see that patients trust physicians more than AI for diagnosis, incorporating latest research, individual responses, and clear explanations. The influencing factors were trust in AI correlated with affinity for technology, but it was not significantly correlated with age, education, or illness perception. And there was AI in diagnosis. There was a higher trust in AI when it was controlled by physicians than when AI was used alone. So patients are okay with AI as long as it's not individualized and without a physician supervising it. How about AI in patient education? The AMA recommends that health information be written at a 6th grade level, reading level, which is ages 11 to 12 in the United States. When the reading level was determined when they looked at content that was available online for patients to look at for education as it pertains to patient education in general, it was equated to that of a 10th to 12th grade student, so ages 15 to 8, so a little bit too complicated for your average patient. However, the text generated by ChatGPT was considered considerably easier to understand, with readability levels measured at as low as 5th grade, ages 10 to 11. So again, ChatGPT may be better at communicating messages to patients as opposed to physicians. Moving to AI in surgery, it can be used in the preoperative setting for image analysis, tumor detection, decision support. Here you can see different ways that it can be used preoperatively. It can be used for surgical assistance. This can be used in robotic surgery, which we've all seen with some haptic feedback. It can be used for lesion detection, for simulation, for feedback systems. So this is instrument tracking, tactile feedback, error detection, depth perception, and augmented reality. So to help enhance, you can have a 3D image of an implant, as you can see here, which may help surgeons and residents when they operate. And it can help with recovery, complication, and enhancement of the postoperative outcomes. Moving on to AI and academia. So it can be used for many instances for automated grading, for research assistance, for personalized learning, for chatbots, language learning, facial recognition for attendance, robotics in the lab, virtual labs and simulation, automatic transcription, plagiarism detection, art and creativity, and presentation creator. This last one actually is kind of disappointing to me because I had an idea of coming up with a device that allows us to prepare a PowerPoint with the use of AI, but that actually exists. So, for example, you can use Slides AI that will allow you to prepare your slides for a presentation through AI with just some prompts. So again, the technology is there, and we just have to learn how to use it. Moving on to AI and sexual medicine. So let's dive into a world where AI meets pleasure and where things get spicy with a touch of technology. When we look at AI and erectile dysfunction, you can use ChatGPT and other chatbots, which may provide accurate answers to common patient questions pertaining to ED. You can diagnose and predict erectile dysfunction through charts, genetic surveys, biomarkers. You can use some of these new apps such as Adam Health and FirmTech, which are examples of how you can check for your erectile health at home with regards to erections, tissue oxygenation, fibrosis with these wearable devices. But you can also identify new treatments. Yang et al., for example, use AI to identify the functional role of uridine in the treatment of ED in diabetic rats. Moving on to AI and Peyronie's. Here you can measure various degrees of Peyronie's disease from patients' uploaded pictures. It can be potentially more practical, consistent, and accurate. So the SMSNA and Endo have an app where a patient can upload pictures of his penis, and this has been shown to more accurately measure compared to the naked eye, a photography, or a goniometer, and less intra-observer variability that you can get from two providers who are looking at the same penis. But not only can it diagnose the Peyronie's disease and directly locate a provider, but it can also directly locate a provider through the app, so an added advantage. Moving on to AI and priapism, this is a study from the University of Miami. They predicted shunt requirement in ischemic priapism. So they looked at 334 encounters of ischemic priapism. Shunting was required in 10% of the men. The mean duration of priapism was longer for men required shunting, and patients with sickle cell disease were less likely to require shunting. And using their online probability calculator, they had an 87% accuracy using AI, depending on patient visits to the emergency room. AI and sexually transmitted diseases. Chatbots can give general knowledge, prevention, diagnosis, and treatment of STD. AI's diaries can be used for treatment adherence and prep strategies and adherence, particularly in patients with HIV. Direct transmission patterns can be assessed, and interestingly, it can analyze surveys to detect the risk behaviors associated with contracting HIV through assessing social media and other issues inside a patient's chart. This is really interesting as AI and STD lesions. So AI can differentiate sexually transmitted infection lesions from non-STI conditions. So there are two models. The top model, the orange one, is the convolutional neural network, which just takes an image-only model and can tell you whether it's an STI or a non-STI. And the second one is images and metadata. So the age, the gender, the lesion site, is it itchy, painful? So some clinical characteristics into a fully connected neural network. And the integrated model, which included both of them together, achieved a higher accuracy compared to the image-only model. And an AI-based mobile app has a higher diagnostic accuracy compared to primary care physicians and similar accuracy to dermatologists. So if you're in your practice and you see someone with a lesion, you can just take your phone and take a picture of it and can potentially give you a diagnosis. AI and female sexual dysfunction. It can investigate the role of core muscles in female sexual dysfunction using machine and deep learning models. Here, the figure represents the machine learning workflow for predicting which core muscles were involved in relation to FSD. So basically, there's a multi-layer perceptor, long short-term memory, convolutional neural network, recurrent neural networks, elastic, net, CV, random, forest regressors, etc., which essentially can help you train and predict the reasons for the female sexual dysfunctions. So machine learning can effectively predict changes in core muscles, highlighting the need for rehabilitation programs targeting core muscle strength to improve FSD outcomes. AI and sex tech in males, we have penile vibration stimulations for anejaculation. A device is the Vibrect X3. We have smart masturbation aid devices that help with premature ejaculation, such as the Flip Zero and the MyHixel. And then we have sex robots that can be catered towards the elderly, patients with disabilities, and patients who have relationship issues. We have also AI and sex tech in females. So we have clitoral therapy devices, which allow for sexual arousal and satisfaction. One such device is the Eros CTD vacuum device to the clitoris. We have smart pelvic floor muscle training devices that work on the pelvic floor. This is an X-shaped along the axis of the vagina with a tail exiting and curling forward towards the pubis and does measurement, biofeedback, and metrics. Vibratory devices with smart features are also there for sexual arousal, desire, and orgasmic disorders. One of them is the Linus Vibrator 2.0. And then sex robots are also available for elderly and patients with disabilities or relationship issues. And here, for example, I went down the rabbit hole of looking at sex dolls online, and you can see here an example of a real doll, and this is an AI-driven doll that can follow you and can have expressions, moves its head, etc. But these devices are pretty expensive. They can cost up to $4,000 to up to $7,000, depending on how much you put into it and how much you customize it. And once I went even further, you can get a device like this. You can get a sex robot like this one, looking like Dr. Omar Rahim, who's put together these webinars. There are some issues, however, related to sex dolls and sex robots. So there are some issues about child sex robots that may encourage pedophilia. There are general bans in some countries. Some countries have narrow restrictions and consider it prostitution, however. There's some data privacy. If you're having sex with a robot, is your data shared with anybody? And then there's the AI framework. Who is overseeing the algorithms and how are these being put together? Moving forward to AI and sexual behaviors, it can detect factors that predict sexual desire by tracking social media. Can detect sexual dysfunctions by analyzing health records, comorbidities, drug treatments, and questionnaires. It can detect problematic sexual behaviors. Wang and Kosinski from Stanford controversially suggested that AI can predict sexual orientation from facial characteristics and can even predict infidelity. Moving on to AI and infertility. So here you can see testis ultrasounds can be done to predict gonadal and reproductive function and have been shown to have some kind of correlation with semen parameters. Testis ultrasound to classify lesions of testicular tumors, and shear wave elastography in varicocele, undescended testes, and testicular macrolithiasis can also be done robotically. We all know that we can do automated sperm analyses that can quantify DNA damage or alternative markers and detect sperm capacitation and hyperactivation, and all these can be done through a AI run program. But AI is also used in assisted reproductive technology that can predict fertilization during IVF. It can predict a sperm and oocyte selection for ART, predict embryo quality, predict best treatment regimen, and analyze key successful factors. There are some ethical issues in urology related to AI. There's privacy and data security, confidentiality, who owns the data, algorithmic bias. So for example, if you took ChatGPT and you compare it to Gronk, that is the one that's been put together by Elon Musk and X, they may show you different ideas and different results based on the same question that is being asked. It can issues with informed consent, accountability, and liability. For example, take two Tesla cars that auto-driving Tesla cars that bump into each other. Who's liable? Misinformation, and there's also some lack of transparency. So in conclusion, urologists acknowledge the promising potential of AI in both research and clinical applications. AI is progressing and increasingly integrated into the field of urology, particularly in sexual medicine. There are concerns that persist regarding accuracy, ethical concerns, acceptance, and regulatory frameworks, and we need to develop guidelines to ensure the effective and safe utilization of AI. Finally, a special thanks to Dr. Omar Rahim, who helps with the framework, and our research fellow, Aliyah Abu Shawarib, who will be present today to answer any questions. He is a whiz when it comes to artificial intelligence and was very helpful in helping me gather all the available data. And I'll end by saying the creation of this presentation was a collaborative effort, and AI played a role, but wasn't smart enough to be solely responsible for its production. Thank you for your attention.
We already have some questions in the Q&A button, but we will address the questions and comments at the end. And maybe now I can introduce you to Dr. Flavia Fairbanks. She will be talking about Botox for vaginism. Is it the cure? Dr. Flavia Fairbanks is MD, PhD, is an associated professor of clinical obstetric and gynecology and reproductive science at the University of Miami Miller School of Medicine. Is currently Dr. Ruano is currently the director of the Female Sexual Health Program, and Dr. Fairbanks' clinical research and practice focus on advancing sexual health care for women from reproductive years to the postmenopause. So thank you for having you, Dr. Fairbanks. The floor is yours.
Thank you so much, Stella, for this nice introduction. And thank you, the ISSM Scientific Committee, to include my name for this webinar that I'm very excited to be part of. So next slide, please. I have no disclosures to disclose today. And first, we need to talk about vaginismus a little bit prior to decide about any kind of approach or treatment. So what is vaginismus? Vaginismus on a physical basis is defined as the persistent or recurrent difficulty in vaginal entry of a penis, dilator, finger, or any other object, despite the desire of the patient or the woman to do so. On a psychological basis, it can be defined as a disorder based on a fear, anxiety, and induces, of course, the pelvic muscles dysfunction. So we can be adding both diagnosis or definition. And of course, in addition to that, we have some other markers that can be part of this diagnosis, and they show a high tonus of the pelvic muscles function and dysfunction. And these patients, of course, do and present any kind of behavior avoidance. It's something that affects a lot of women, and we need to be aware about. In 2013, the American Psychiatry Association defined vaginismus and classified it in combination with the genital pelvic pain and penetration disorder in parallel with the dyspareunia. But we know nowadays that this definition is currently being reviewed because many authors disapprove this kind of definition because they are completely different entities. So there is no current definition that includes everything under the same umbrella. We need to address each one of them in a different approach for sure. And vaginismus can affect up to 17% of female or women, and many factors can be included or involved in that. So we need to discuss about sexual violence, traumatic sexual experiences, strict religious and education, some emotional issues as well. So it's something that we need to be very close to the patient to decide and to study whenever possible. Next slide, please. We know nowadays that the research on vaginismus is increasing, and we don't know exactly why is it happening, but maybe it's a social claim because we know that patients are looking for solutions and they are not like mostly of them are not even so only expectant of their health issues. So when they see a situation, they look for information, they look for centers where they are able to be seen, and this is really, really important. So according to PubMed, can we go back to the first slide? We can see the raise of the numbers of vaginismus research nowadays that they're much, much bigger than they were before. Next one, please. And there are many classifications on vaginismus, and one of them is considered a very simple one. It's effective, so that's why it's considered like worldwide effective and useful. This is called the Lemon Basic Scale, and I want to tell you a little bit and show you how do we classify it. So a patient will be considered Lemon grade 1 or level 1 when she's able to relax for a pelvic examination. Level 2 would be the patient that is not able or unable to relax for this pelvic examination, but she still allows us to do that. Level 3 will be the patient that starts presenting any kind of severe behavior avoidance. So we are not even able to get close to her. Level 4 would be the patient that includes everything in terms of this behavior avoidance, and she is presenting like physical symptoms that are very, very easy to be known and realized. So people say that this would be the worst scenario, but it's not, because then Dr. Pacey included grade 5 or level 5, which is the patient with all of the previous alterations. And also, in addition to that, the physical challenges and alterations such as palpitations, hyperventilation, sweating, severe tremors and everything. So these patients from grade 3 to grade 5 are, of course, the most challenged ones, and the ones that we usually see on our like specialized centers. Next one, please. And what are the possible interventions for vaginismus? What do we know? In 2012, the Cochrane Library decided to study it and published this study. It was a very short one. They tried to conduct a meta-analysis, but they were only able to include 280 participants. And due to the very, very heterogeneous amount of, and less, the samples were very, very short, they could not be defining any kind of best approach for that. They were trying to compare desensitization and also emotional instructions, including therapy, group therapies and everything. And at that time, they were not able to define about anything. So it was the first study that was like really trying to establish a protocol for vaginismus, but it was not enough yet. Next one, please. And since then, we know that the vaginismus treatment options include the dilators, vaginal dilators, the physical therapy with or without the biofeedback, the biofeedback isolated, the sex and relationship counseling, psychotherapy, the cognitive behavior therapy, hypnotherapy, and sometimes lubricants. None of them yet are enough to define the best protocol. Next one, please. And Botox for vaginismus was first described in 1997. At that time, science knew exactly what were the indications for using Botox in the medical field, but no one had still started with Botox for vaginismus. So they used very, very low doses. And after that, many studies start to be published on this field. The positive outcomes encouraged students and researchers to conduct many other papers on that. So nowadays we are seeing many more protocols, including vaginismus, using Botox for them. We can see the next one, please. And in 2017, Dr. Pacey and colleagues, they published this polyclinical trial that was very, very well designed. That's why we wanted him to be present here. And they were able to enroll more than 240 patients. The majority of them were level 3 or higher basic level. And many of them were presenting the vaginismus symptoms for more than 8 years. The average age for these patients were around 30 years old. And they reported that they tried everything they could, including lubricants, dilators, the Kegel exercises, sexy counseling, hypnotherapy, antidepressant, anti-anxiety, so everything they could. And these patients have failed on this previous treatment. So that's why they were enrolled on this new protocol. Next one, please. And what did they do? They decided to combine multiple techniques, and they started seeing patients and injecting the Botox 50 units at each side of the bulbospongiosus muscles, immediately behind the hymenal carbuncle. And what did they exactly do? They started seeing these patients in a group, and they developed a new protocol that I want to describe for you. So next slide, please. They started interviewing patients and applying the FSFI immediately. These patients could be with a partnership or not, and it was allowed to the partner to participate during the whole protocol whenever the patient agreed with. So after applying the FSFI, they brought the patient to the OR, and then they performed a conscious sedation. And during the sedation, they were able to introduce or start with the dilation. They used this conscious dilation model, and they went to dilator number 6 or plus. And then what was their guidance? They wanted the patient to keep the dilator for 24 hours, so she was charged at home. And after having this dilator for 24 hours, patient and the partnership went back to the clinic. And at that time, they were able to realize that they were seeing many improvements during this 24 hours that as they've never seen before. And that's why they consider this protocol very, very important since the beginning. So they guided the patients to use the dilators for 2 hours per day during the first month, and then 1 hour per day during and from the second to the 12th month. And if the patient decided to give up on this protocol, the chances of recurrence were very high. So they were insistent, and they were like contacting the patients every single week just to guarantee that the adhesion to the protocol was very high. And the recommendation was to keep the dilator at least 15 to 30 minutes a day during this 12 months. And the outcomes were very, very positive. Botox showed to be effective for 4 months for their sample. The FSFI levels and scores after using this protocol improved a lot. 70% of these patients were able to get pain-free intercourse after completing this 12 months protocol. So they were very enthusiastic on their protocol, and they spread it worldwide as well. Next slide, please. And what was the beauty of this study? They were able to prove that they were only adding something else, the Botox injections, to everything that we knew, the multimodal and also the multi-professional and multidisciplinary protocols for vaginismus that were already in use. Using the dilation under anesthesia, of course, gave the patient the possibility to participate. And this was something very, very different because they were able to offer the patient the possibility to participate in her own dilation. That's why she had the conscious dilation under a superficial sedation. More than 170 patients participate for the full protocol and showed this kind of 75% improvement scores on the FSFI. Next slide, please. Well, still talking about Botox, another paper was published in 2022, and they tried to compare the different protocols that were available at that time. But according to the study and the discussion, they weren't able to find anything that could be established as a good protocol because the studies were completely heterogeneous. On the other hand, they were able to analyze and evaluate the side effects of using Botox for these protocols. And these side effects were mostly involved and focused on the bladder effects and also the bowel effects. And everything seemed to be completely reversible after stopping with the protocol. So it was not considered a reason for not using them when patients really needed it. Next slide, please. And another one tried to compare the dosage of Botox. So if they were able to inject 150 or 200 units of Botox for the pelvic floor spasms. And they enrolled more than 90 patients with a mean age of 30 years old, and the similar outcomes from 150 and 200 units were able to be seen. So they defined that 150 units was more than enough to give the patient the comfort that she needs. They also noticed that It was only related to pelvic floor muscle spasm, but it helped a lot with anxiety and fear feelings and symptoms for these patients. So it was another study showing the improvements after using the Botox for vaginismus. Next slide. And then last year, an Italian group tried to conduct another meta-analysis in the same way that the Cochrane Library tried to do in 2012. Now they had more data, but they weren't still able to compare the studies due to the heterogeneity of the methodology, the number of participants, the samples, the dosage of Botox and everything. So we are still a little blind in regards to the best one to be applied to our patients, but we know that we are going in the correct direction. Next slide. And it's also very important to highlight how do a patient behavior when she has like this multiple attempts to treat without any kind of success. So these unsuccessful treatments for the hand, let them to try many times or attempts for penetration. And when they try penetration and with a negative outcome, they can have like two different pathways. They can start having the catastrophizing thoughts that induce pain, fear, anxiety, behavior, depression, and everything. And it comes in a negative cycle, which is very difficult for us to treat and to interfere. In another hand, when this patient is involved in any kind of protocol that helps her in their understanding that catastrophizing thoughts need to be completely avoided since the beginning, she's participating in anything in regards to her own health issue. So then she starts presenting being more open to any kind of approach, and the confrontation and penetration, in another hand, can be possible in the future. So it's important to discuss with them about the new techniques, the new models, the novelties that we can present them, and of course, for sure, that they can be part of this treatment and the protocol itself. Next slide, please. We cannot say that the Botox for vaginismus is a cure, like the question we presented before, but it's an option. It's a real option. It's something new that's bringing to the market a new possibility for enrolling more and more patients that were completely failing on the previous ones. So we are excited about these protocols that they show some outcomes that are very interesting for everyone who works on this medical and the sexual medicine field. Next one. And of course, we always need to involve the sexual partner when possible or present, because his or her and they are part of the protocol and of course of the treatment. So every time the patient to have the sexual partner, it's difficult for her to block this field of anxiety, depression, and sometimes fear about the partnership. So of course we need to discuss with the partner. We discuss first of all with the patient, and when she allows the patient, the partner to be part of that, we include both of them. So respecting individual, the intersocial, and the relationship is also important part of these protocols as well. So every time we can see them together, it's better for the protocol, of course, and it's much better for the partnership, for the couple, and for the sexual life quality. Next one. So I thank you so much for your attention. I'm open for any questions.
And moving on, we will have now the presentation of Dr. Sidney Glina on advancement in therapy for erectile dysfunction, novel agents and treatment strategies. You know, Dr. Sidney Glina is head of the Division of Urology at Centro Universitario de Santo André, Sao Paulo, Brazil. He was the past president of ISSM and past president of the Sociedade Brasileira de Urologia, editor emeritus do International Brazilian Journal of Urology. So thank you for being with us, Dr. Sidney Glina, tonight, and we are willing to hear your talk tonight. Thank you.
Oh, hello everybody. Hello Stella, Flavia. It's a pleasure to be here. I thank ISSM for the invitation. I apologize because the last 2 days I have a terrible cold. I'm not feeling too well, but I think I can do it. Next slide, please. Those are my conflict of interest. Next, please. This is an algorithm that I like very much. It's from Academia Internacional de Sexologia Médica for the patient with erectile dysfunction. You have the patient with ED. You can try lifestyle modification. It's not easy, but we always need to do. If you have a psychogenic ED, you can use sexotherapy or counseling or the oral treatment. If you have a ED caused by a medication, you can try to withdraw medication, but sometimes it's not possible. If the patient has a severe depression, maybe it's better to use an oral treatment. If you have a vascular or neurogenic ED, you can try oral treatment or intracavernous injection or penile implant. If you have a hormonal ED, you can use testosterone replacement or treat the hyperprolactinemia. Próximo, next. This is another classification that I like very much. I used to classify the treatment as curative treatments. If you have a psychogenic ED, if you have a psychotherapy, you have a good chance to cure the patients. Or you have an organic ED, you can do a penile implant, you have a cure. Or you can have a palliative treatment where the patient needs to use every time he'll go for a sexual intercourse. You can have the oral treatment, mostly the PD-5 inhibitors, intracavernous injection, or in some places you can use the vacuum device. Next. Next. There are new PD-5 in the markets. There is a new routes of administration at the meeting in Rio. It was presented a oral dispersible sildenafil. You have some other PD-5 inhibitors that are in research. This is the TPN. It's a Chinese drug. It has good safety and efficacy profile in rats. It was never tested in humans. This is another analogous of this drug. It's a powerful PD-5 inhibitor. So it can be used in research. Next, please. You have another class of drugs. Here you can see how the smooth muscle relaxation occurs. You need to have a activate of the guanylate cyclase to produce the cyclic GMP, and you have drugs that can activate this enzyme. Next, please. Many years ago, Bayer presented two drugs, two compounds. At the time, in 2015, the question is, would they work in patients who do not respond to PD-5 inhibitors? To be a combination of drugs. One will activating the guanylyl cyclase, and the other inhibiting the phosphodiesterase. Maybe you can improve the action. Next. In 2013, it was presented a paper with this combination. They are studying rats, showing that there is a synergistic effect. But because of financial issues, this class of drug was launched just for pulmonary hypertension. This is the drug. The commercial name is Rio Sequate. It has an effect on erection. But because of because we have very low price PD-5 inhibitors today, there is no incentive for the company to launch this for ED. Next. It is another interesting area. We know that, next please, rho kinase has a facilitated vasoconstriction activity in the penis. If you block this activity, you have a vasodilatation and an erection. And we know at least 10 drugs that have been tested for their rho kinase inhibitor activity. Next. But we have drugs. They have been researched. Why there are no new drugs being released for the treatment of erectile dysfunction? First, what we call ceiling effect. The PD-5 inhibitor has a very power effect, and it's very hard to compete with them. And the other is the financial factors. The patients of the major PD-5 inhibitors have expired or are expiring, leading to a surge in generic versions. Pharmaceutical companies may see less financial incentive to invest in research for new oral medications that would compete with these well-established low-cost options. So we know that we can have a new drugs, but because of financial factors, we probably won't have them. Next. This is an interesting. We cannot call drug because it has no an active medication. Really, it's a gel that freezes the glands, and in some patients cause a reaction that can lead to an erection. Next. There is a study. It was a randomized double-blind placebo-controlled study. More than 200 patients were tested. And overall, 23% of the patients showed a clinically relevant more than 4 points in IEF scored after the treatment of that drug at the time was MED 2005, and only 14% responded to placebo. So next, this compound was launched in Europe. You can buy there without a prescription. It's a OTC. It shows that maybe for some men, it's an option, but maybe psychogenic man that has a intact penile erection mechanism, so maybe it can work. Next. Let's talk about the other options. Talk about the shockwave therapy. It's not a very new drug. Next. Treatment, sorry. There is a rationale in experimental papers. It can increase the vascular endothelial growth factor in animal models. In humans, it showed some role in the new vascularization of the myocardium. It's when you can treat diabetic foot ulcers or healing wounds. So something happened when you use PD-5 shock waves. Next, please. In animal model, it's the low intensity shock wave improve the erectile function diabetic rats, increase the content of smooth muscle endothelial cells, and increase some neurotransmitters. So you have a ratio for that. Next. We conducted a study some years ago. It was a control randomized study on patients after radical prostatectomy. We combined tadalafil 5 milligrams daily with the shock wave starting just after the radical prostatectomy, and we got a slight effect, a significant effect in the group. After 9 months, it was a small increase, and IEF was 12 against 10. It's a sign that something can be done using the shock wave. It needs more studies, but it's at least a sign. Next. The guideline of EAU, they wrote that the use of low-intensity shockwave therapy has been proposed as a treatment for vasculogenic ED over the past decade. And if it works, it's the only currently market treatment that could offer a cure. However, data from prospective randomized trials are conflicting. Many questions remain unanswered due to the heterogeneity among shockwave generators, type of shockwaves administered, setting parameters, and treatment protocols. Next. Why this therapy is still a contested and controversial therapy after 15 years? There is a rationale. I showed you that there is something happen when you use shockwave. The problem is the patient selection is crucial for treatment success. You cannot use that in psychogenic ED patients. You need to diagnose a vasculogenic ED. Maybe there you can have a success. There is no established treatment protocol. There are no comparative studies between different machines. We don't know if machine A is the same as machine B. At this time, better studies are needed before shockwave can become the gold standard for the treatment of vasculogenic erectile dysfunction. And we need studies comparing the machines and protocols. Next. And the other problem, you have at least two different shockwaves. You have the focal shockwaves that it has a deep action and maybe it can work. And you have the radio devices that they have a superficial action and probably doesn't work in improving the vascularization of the corpus cavernosum. Next. And there are three technologies to generate shock waves. Sorry. We have the electrohydraulic, electromagnetic, and piezoelectric. And we don't know if they offer the same shock wave, the intensity are the same, and which protocol you can use with each one. Next. So we don't know if we are talking about the same machines. You are talking about apples, pears, or pears and apples, or even pineapples. Probably we don't. We need to compare the machines and to do a study that can tell us that they are giving the same shockwave. Next. Another area it's growing in the literature is the stem cell transplants. You can have stem cells from the adipose tissue, from bone marrow, from the muscle, and from embryonic stem cell. Next. Again, we have a rationale to use for ED. There's a regenerative option to repair damaged tissues, might promote cell growth, proliferation, neovascularization, revitalization, immunomodulation. Stem cell therapy has been proposed to treat ED, as stem cells can differentiate into endothelial, neuronal, or hemosmus methyl cells, and maybe can restore possible structural damage to the penile tissue. Next. A systematic review, it's the guideline of EAU. A systematic review has concluded that 5 completed human clinical trials have shown promise for stem cell therapy as a restorative treatment for AD. However, the data is still insufficient to provide a clinical recommendation. Next. Because we don't have a standardization of the protocols and the technologies, and again, patient selection is a big problem. We don't have a very strict diagnosis of vascular ED or for neurogenic ED. A lot of people are giving the therapy for everybody, considering that everybody has an organic ED. It's not true. Again, another area is the platelet-rich plasma. Again, has a possible rationale because like stem cells, PRP has stood as a regenerative therapy, and there is some neurotransmitters that you can improve. It can show that it can lead to a preclinical and clinical studies. Next. EU again say that there is promising results. However, the evidence is still insufficient to provide a recommendation. Again, there is still significant heterogeneity between studies in terms of timing, dosing regimens, with no consensus on the optimal activation method and platelet concentration for each PRP injection. Therefore, intracavernoso injection of PRP should only be used in clinical trial setting. Next. Again, botulinum toxin. Again, we have the rationale because we know if you inject the Botox, you have a relaxation of the cavernous smooth muscle by inhibition of norepinephrine of the adrenergic neurons. So if you the botulinum toxin has a muscular relaxation action. There is a study from Giuliano. It's a very interesting study. It's a retrospective study. They use very many botulinum toxin in men with erectile dysfunction, and they didn't respond to PD5 or intracavernous injection of PG1. Next. Next, they studied the patients that. Next, please. They studied just the patients who had more than 2 injections. And you can see after each injection, there is an improvement of the IEF, and it disappears after some time, but showing that maybe this is an area that deserves more research, because apparently there is an action and it can improve the erectile function of some patients. Next. And the meeting in Rio, a paper from Dr. Gabriel Moreira Kreller from Brazil was presented, showing again interesting results with intracavernoso botulinum toxin. Next. It's my last year. It is a very interesting study. It was published some years ago about the low intensity electric stimulation. They studied rats that had a cavernous nerve injury, and they showed that when you stimulate the nerves that had been injured, you have the stimulation, the low intensity stimulation protects the cavernous nerve structure, improve erectile function recovery of the rats, and prevent a remodeling of the corpora cavernosa. Next. So a company developed a stimulator. This is the name. The commercial name is Cavertine. It's still under research. Next. And they are studying two groups of patients. One group is a patient with spinal cord injury, and another is a study on immediately patients with immediately study on patients of post-prostatectomy, radical prostatectomy as a rehabilitator. Next. We can see here. This is the second figure on my right. You can see the neurostimulator that is implantable is over the lateral face of the prostate. This is in patients with spinal cord injury, and so you have a stimulator that is placed on the belly of the patient. It is continuous send stimulus to the nerve of the patients. Next. And we have conducted this study. It's a pilot study presented in Rio. We have 7 patients. You can see there was a improvement on erectile function of those patients. Those patients were patients who responded to PD5 inhibitors, but here, without the PD5 inhibitor, they had an improvement on erectile function. Next. And this is another study that has been conducted in Australia. And the primary objective of the study is to assess the safety and tolerability of the cover steam device by monitoring the occurrence of diverse events following implantation, and to assess the tolerability of cavernous nerve stimulation in the prostatectomy, and to evaluate the effectiveness of this stimulation in treating and/or rehabilitating erectile function post-prostatectomy. Next. Next, it's easier to see the. Oh, they studied up to now 6 patients have is implanted with cover steam. No serious event has been observed, and when they send the reel, they have data from 3 patients, but now they have 7 patients, and we can see the baseline IEF, and after 30 and 44 days of post-operative, and you see that there's an increase in terms of like maintenance of the IEF after the radical prostatectomy. And patients were studied with Vigiscan, and they all of them have a nocturnal erection or are completely full after 180 days post-op. Next. I think this neurostimulator can be maybe it needs more patients. So we start here in Brazil a study of radical prostatectomy too, and probably we maybe can be a way to rehabilitate the erectile function just after the radical prostatectomy. I think we are now in a much better position than we are in the 17th century, where Nicolas Vanet said that if a woman's hand, which is undoubtedly the best medicine, cannot remove the penis from its flaccid states, there is little other medicine can do. But now we learn much more. Thank you very much.
And about how to predict some cases of people getting to have sex work and no, I'm sorry, sex crime. I refer to it. It would be good to have some inputs on sex work and sex workers too. Can AA predict who may become a sex worker and the other ethical implication of this application? I think it is very challenging for artificial intelligence to come to the sexual medicine setting. I believe it is quite interesting to understand how it works and to know that it doesn't fit it doesn't fit all of, I think.
Hello, thank you for having me here. For the first question, for the data on AI use, the one presented in the presentation are just on AI use in the US. There's a website called AI Index that shows all the stats of AI usage in all places, like in healthcare and economics and different different phases and different types of businesses all over the US. For the second question, to see some inputs on sex crimes, there are several studies that show that sex robot did not affect sex crimes. However, there are some that shows that it might empower sex offenders to make more sex crimes. Also, according to sex workers, another study that shows that where there was an increased demand for sex robots did not show a decrease in demand for sex workers. And some of the ethical issues were like the need mostly due to privacy breaches, lack of consent for the robot and for the owner of the robot, and the potential for exploitation, like using the robot to be a sex worker. And the main concern was also a biased training, where, depends on the algorithm that the robot was trained on. It can be biased towards gender or towards an ethnicity or towards preferences of different patients. And also, the robot has a main issue that had a misrepresentation of human intimacy. I guess I covered all.
Yes, I think. And I am curious about the use of sex robots for pedophiles, because as I understand, it was like one of the so-called solutions for this kind of patients, and I recall reading an article saying that it was actually not being that good for this kind of.
Yes,
Am I right?
that's true.
Okay.
It showed that it was an empowerment tool that increased the pedophile ratios and their crimes. Therefore, but in the US, there's a law that prohibits the production of child sexual robots.
Yes, it is. It is very challenging, I imagine,
Yeah.
and I guess artificial intelligence is very useful in case of diagnosis, as Dr. Yafi mentioned, and for training, but it's very challenging to set this in their situation of sexuality itself.
Yes, that's true.
Okay, so moving on to some questions referred to the presentation about vaginismus. There was a question like if there were some MRI studies for vaginismus, and if these are valid for psychogenic ID.
Well,
Yes, go ahead, please.
yeah. So I'm not aware about any studies in regards to functional MRI. I saw the question in regards to functional MRI and vaginismus nowadays. I'm not aware, but I can look for that and I can reply later if possible.
My comment to your presentation is that I don't know if this happens to you in your practice, but I have some patients coming to say, can you just knock me down and just open up my vagina like it's like kind of miracle, so that I can wake up and have no problem anymore. So I was thinking that maybe this technique can help, and also I would like to see to know your thoughts about how multidisciplinary this treatment should be, right? How
No, for
do you
sure.
feel about this?
I think this new protocol is like very interesting because it includes everything that we already know, and the use of dilators, the importance of having a partnership involved and everything. But in another hand, the patient was never included herself. Everyone was trying to give her a solution. But now they were able to prove that including the patient under this conscious sedation, which means that it's a very, very superficial sedation, only able to give her at least a relaxation. And then she was the one who inserted her own dilator, and she was seeing and feeling that it was possible. Then she moved to the next one. And then the partnership was also included sometimes in giving her this permission to, okay, you can do it, I can do it with you. So it helped in a way that they were able to bring that practice home as well. So it was important for them to see that they were able, and they didn't need someone to do that, because blocking it at the beginning or breaking that negative cycle at the beginning was important to see that there was a possibility. And they showed that those patients, they tried everything they could prior to get enrolled in the protocol. So they were open, because that seemed to be the last solution. Okay, if it works, perfect. If it doesn't work, it will be like I'm not the one to do that anymore, you know. So that's why I was interested in the protocol, and we are trying to apply the same way here. We are trying to establish the protocol as well here.
And related to the dosage, what's the dosage you usually do?
So that protocol used 100 units, and the other studies used 150 and then 200. I think that 100 is enough. Yes, we are trying to apply exactly the same protocol.
In each
Yes,
muscle,
50,
right?
yeah, 50 units at each side.
50 units at right and left.
Yeah,
Okay.
immediately behind the hymenal caruncle.
Okay. So it is very interesting because I think, as you say, vaginismus is quite a common situation, clinical situation for women, and many of them have not had the opportunity to talk to their physician, not to their gynecologist, not to the psychologist, and many of them are very frustrated already when they arrive to the clinic. So if you give some positive feedback and some good outcome in papers, this should help. I'm quite sure of that.
It's a kind of hope, giving hope.
Yeah, of course. And there's another question for you, Dr. Abu, in the chat. But in the meantime, I would like to say to Dr. Glina that as I was hearing you, I think it is more than obvious that, as usual, appropriate treatment is the best approach for each patient, because you were talking about how important is to have the same machine for the shock therapy and the adequate treatment for post prostatectomy patients, but it doesn't, one size doesn't fit all in this. And erectile dysfunction also shares with vaginism the problem of frustration, and as it comes in many shapes, many patients already also have very life-threatening disease like diabetes and hypertension. And so it would be great to have one thing for all of them, but unfortunately we have to work together in many cases. Do you agree with this, that we should try to have the best understanding of each patient in order to avoid unnecessary treatments?
Oh, you are absolutely right. I think ED is not one disease. When you say erectile dysfunction, you are talking about many causes, many situations. It can be psychogenic. I think many cases are psychogenic. You can be vasculogenic. You can be, and you don't have one therapy for everybody. No, you probably need to select and make a diagnosis, and that after that you can treat it. I think all this is miraculous solutions, that you have a machine that can do a shockwave or stem cell. I think you need to be careful, because probably you are treating many psychogenic patients with these machines. It won't work. So I think you need to make a diagnosis, study the patient, and a multidisciplinary approach. And after that, you can treat it.
And also, maybe, I don't know if you all agree, but the fact that social media is always showing us how beautiful and how young and how great you are, and this is also always related to sex performance, and this causes a lot of stress because we are not like that. And the effect of pornography is also very important, because we are not like that as well. So I think it always comes sexually, the opinion, how you approach these patients should be also multidisciplinary and coming from for an education approach. And I think that we are very different, and we might need different approaches as well. So I don't know, Doctor, if you had the chance to review the other question.
Yes, there are two questions, one in the chat and one in the question and answers. So the one in the chat, that with regards to AI and sex crimes, Yes, it can be predictive. There's an already published study that shows that AI can predict sexual behaviors in different types of sexual issues. So yes, it can be. And for the other one, do you think AI, LLMs or large language models are better than machine learning? LLMs are part of machine learning, and we do use both, but they are not the same thing. For example, machine learning is used for prediction, while LLMs are used for chat generation, like ChatGPT and other stuff that understand the language. You type in and they answer your request. So I can't say it's better or not because they are two different types.
When it comes to different approaches of well, of course. So I would like to thank you all for being here. It was great to share this webinar with you. And I hope to see you soon, hopefully in the next meeting.